Hello, everyone, and welcome to This Explainer. Today, we are decoding thyroid, a complete picture. We're drawing directly from the definitive insights of Harrison's Principles of Internal Medicine to explore our body's master metabolic factory. I mean, if you've ever wondered how a structure weighing literally just a few grams can completely dictate your energy, your heart rate, and your weight, well, you're in the exact right place. Here's our roadmap for today. We'll start with the basics of the thyroid, then move into iodine and synthesis, followed by physiology, thyroid diseases, and we'll wrap it all up with some real-world clinical cases. All right, let's jump straight into Section 1, Basics of the Thyroid, Anatomy and Command Center.
So nestled right there in the lower neck, we have this small but mighty butterfly-shaped structure. It essentially acts as the metabolic engine of your entire body. But here's the thing, it never operates independently. It actually takes strict, precise orders from the brain, functioning within a highly regulated hierarchy. This is the hypothalamic pituitary thyroid, or HPT axis. It's a classic endocrine negative feedback loop. So the hypothalamus secretes TRH in pulses, which then prompts the anterior pituitary to release TSH. TSH goes on to bind to receptors on the thyroid gland, commanding it to synthesize and release T3 and T4. And as those hormone levels rise in the blood, they exert a negative feedback effect. Basically, they tell the brain to dial back the stimulation. It really is biological precision at its finest.
Moving on to Section 2, Iodine and Synthesis, the raw materials.
The absolute foundational ingredient for this entire manufacturing process comes straight from our diet, and that's iodine. Now, adults require about 150 micrograms per day, but that demand jumps up to 220 for pregnant women and 290 during lactation. The thyroid aggressively traps this dietary iodine, concentrating it against a massive gradient using the sodium iodide symporter, or NIS. Interestingly enough, if you have an acute excess of iodine, it actually shuts the system down temporarily to protect you from overproduction. It's a brilliant little failsafe known as the Wolff-Chaikoff effect. Inside the follicular lumen of the gland, hormone biosynthesis unfolds in 4 tightly coordinated stages. We've got iodide oxidation, organification, a coupling reaction, and finally secretion. And this fascinating chemistry all takes place on a massive structural protein scaffold called thyroglobulin.
But none of those steps happen without a highly specific catalyst, thyroid peroxidase, or TPO. This is the key enzyme driving that oxidation and organification. I want you to really keep TPO in mind, because when the immune system mistakenly produces anti-TPO antibodies, it causes the autoimmune destruction we see in Hashimoto's disease. Furthermore, when we treat hyperthyroidism with dynamide drugs like methimazole, TPO is the exact enzyme we're targeting to halt production.
Let's move into Section 3, Physiology, Delivery, and Cellular Action.
So there is a stark contrast between our two main hormones, T4 and T3. The thyroid mostly secretes T4, but T4 is essentially a prohormone with a really long 7-day half-life. T3, on the other hand, is the biologically active powerhouse. It boasts a short 1-day half-life and 3 to 5 times greater affinity for cellular receptors. Because 80% of circulating T3 is actually converted from T4 in peripheral tissues like the liver, we purposefully prescribe levothyroxine, which is T4, as a convenient once-daily pill. That long half-life provides a nice stable reservoir for the body to convert into active T3 exactly as it's needed.
Once that active T3 gets inside a cell, it alters gene transcription with dramatic effects. In the heart, it drives up myosin heavy chain alpha, which increases your heart rate and contractility. In the liver, it radically increases LDL receptors, actively pulling LDL cholesterol out of your blood. And to regulate your basal metabolic rate, it ramps up the sodium-potassium ATPase pump, which is what actually generates your body heat.
Which brings us to Section 4, Thyroid Diseases, Hyperthyroidism, and Hypothyroidism.
When this incredibly delicate system breaks down, we generally see 2 extremes. Over on the hyperactive side is Graves' disease, which is responsible for 80% of hyperthyroidism. This is driven by rogue TRAB antibodies that constantly and forcefully stimulate the gland. On the sluggish end sits Hashimoto's thyroiditis, the primary cause of hypothyroidism. Here, those anti-TPO antibodies we mentioned earlier are slowly destroying the gland's very ability to produce hormone.
A lack of thyroid hormone systematically slows down the entire body. The patient experiences profound fatigue, a slowed heart rate, and weight gain. Because the liver stops clearing cholesterol efficiently, dyslipidemia occurs.
You'll even see myxedema, which is this non-pitting swelling caused by complex sugars accumulating in the skin. The entire biological system is essentially running on a dangerously low battery.
Now for our final segment, Section 5, Goiter, Nodules, and Clinical Cases.
Beyond just functional issues, structural enlargements are incredibly common. Actually, solitary nodules are found in about 50% of people on routine ultrasounds. The pivotal clinical question we have to ask is always, is it benign or malignant? We answer this by looking for suspicious ultrasound features, things like irregular margins or microcalcifications. And then we utilize the Bethesda system to classify the cells extracted via a fine needle aspiration. Let's see how this all looks in practice. Case 1. We have a 28-year-old female presenting with a 3-month history of palpitations, a 6-kilogram weight loss despite having an increased appetite, a noticeable tremor, and heat intolerance. Her lab work reveals a completely suppressed TSH of less than 0.01. That completely suppressed TSH, combined with elevated free hormones and positive TRAB antibodies, confirms Graves' disease with thyrotoxicosis. We manage this by immediately cooling down that hyperactive gland. We use methimazole to block the TPO enzyme and beta blockers like propranolol to calm her racing heart. The eventual plan will be radioiodine ablation once her state is stabilized.
Now let's consider Case 2, a 52-year-old male complaining of severe fatigue, constipation, an 8-kilogram weight gain, and cold intolerance over the past year. His physical exam shows a sluggish heart rate of 52 beats per minute, and his labs reveal a profoundly elevated TSH of 48. This points to a completely different metabolic reality.
His highly elevated anti-TPO levels confirm Hashimoto's hypothyroidism. Because his gland has essentially failed, his brain is practically screaming at it by pumping out massive amounts of TSH. Management here requires lifelong hormone replacement with levothyroxine, dosed precisely at 1.6 micrograms per kilogram per day. Targeting a normalized TSH is going to simultaneously resolve his fatigue and his associated high cholesterol. Finally, let's look at Case 3, a 45-year-old woman with no symptoms at all. An ultrasound done for a completely unrelated issue incidentally reveals a 1.8 centimeter hypoechoic nodule in her thyroid. Her TSH is completely normal. However, the ultrasound shows highly suspicious features, specifically microcalcifications and irregular margins.
A fine needle biopsy categorizes the cells as Bethesda V, which is highly suspicious for malignancy, and molecular testing detects a BRAF mutation. So this is papillary thyroid carcinoma. While it does carry an excellent prognosis, management necessitates a total surgical thyroidectomy, followed by radioactive iodine ablation to safely destroy any remaining microscopic cells. Across all these different presentations, Harrison's emphasizes one absolute golden rule in endocrinology, the TSH first approach. Because of that exquisite negative feedback loop we discussed, even microscopic, subtle changes in circulating thyroid hormone cause massive, highly detectable changes in TSH. It is hands down the single most sensitive, cost-effective initial test you can run before you ever reach for complex imaging.
Looking at all of this, it really leaves us marveling at the delicate balance of our endocrine system. Seriously, how is it that a gland so remarkably small, nestled quietly in the neck, can dictate the rhythm of every single cell in your body with such absolute, unforgiving precision? Thank you for joining me for this explainer, and keep questioning the fascinating science happening inside you every single